Okay, chapter 14, medical overview, review questions. Seizure patient is having what kind of medical emergency? Respiratory, cardiovascular, neurologic, or immunologic? So think about those. You got four good choices. One of those hopefully makes more sense than the others do. What do you guys think this is going to be? I'm thinking we're probably looking at neurologic, something to do with the brain. Let me get my guy over here. Okay, yes, neurologic emergencies involve the brain and may be caused by a seizure, by stroke, or fainting. Another word for fainting is syncope. Remember, we talk about how important medical terminology is. So syncope, another word for fainting, or when someone faints and they, fall on the ground, the whole thing is called a syncopal episode. So that's what we're talking about. Let's figure out why things are wrong and why things are right. So seizure patient, respiratory, that includes asthma, emphysema, chronic bronchitis. So what we see here is breathing problems. Cardiovascular emergencies include heart attack and congestive heart failure. So all heart emergencies, right? We can expect probably poor cardiac output and all of that kind of stuff. But the heart's not typically going to cause a seizure. Neurologic, well, that's our correct answer because that is what happens. The brain has some issues, and that's what causes a seizure. And then immunologic, if you're unaware of what that is, we're talking about allergic reaction, your immune system. Allergic reactions are a type of immunologic emergency. So those of you that got C, good job. Number two, if an injury distracts an EMT from assessing a more serious underlying illness the EMT has suffered from. Boy, we talk about this a lot, don't we? We talk about not getting distracted by some injury. Like in the lecture, we talked about like an avulsion on someone's head that is not life-threatening, but you see the fatty tissue underneath, there's blood everywhere. You see the whiteness of the skull. All these things can really mess us up. And what does that give us? Does that give us tunnel vision? Does that give us an index of suspicion? Does that give us virulence or a trauma emergency? So we've got what looks like maybe a couple of good answers here if you're not really sure. You could probably fall into a couple of these if you don't know what we're talking about. What we're talking about is tunnel vision, right? We don't want to have tunnel vision. So as an EMT, you should use the dispatch information to guide your initial response, but do not get locked into a preconceived idea of the patient's condition strictly from what the dispatcher tells you. So right away, you get told this person's having a heart attack. You'll hear it on the radio. They'll say, respond to a heart attack. And you go up there expecting a heart attack, and now you done messed up, right? Because you've probably missed other stuff when all you're doing is looking for a heart attack. So tunnel vision occurs when you become focused on one aspect of the patient's condition and exclude all others, which may cause you to miss an important injury or illness. You get so wrapped up on our trauma patient that has a big avulsion, or like you may or may not know avulsion. So basically we're talking about this big skin flap. You've got this huge skin flap, say the size of the palm of your hand, that's like hanging down, and that can distract you and kind of mess you up, your attention. But you're paying attention to that so much that you're missing the airway issue. You're missing that their tongue is occluding their airway and causing snoring respirations. You're missing the gurgling respirations that you're hearing because of all the blood that's in his airway. All of that. So we don't want tunnel vision, right? Tunnel vision is our correct answer. Now let's talk about what these other things are. Because we said if we're not really sure what these are, maybe some of these might sound good. The index of suspicion doesn't sound, if you don't know what that is, not a bad answer if you're just guessing. But the index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries or illness. So it's kind of that feeling that you got on the inside, your gut instinct or something like that. It's kind of, you just have this awareness and concern that, hey, this is a heart attack. So you see someone that's having some chest pain and you got this feeling because of other calls you've ran and you know the anatomy and physiology of what goes on when someone has a heart attack. And you look at all these things, I bet they're having a heart attack. Virulence, that may or may not sound like the right answer or not if you don't know what it is. But what that is the strength or ability of a pathogen to produce disease. Clearly not when we're talking about tunnel vision issues. And then a trauma emergency. The EMT has suffered from a trauma emergency. Well, they could be on a trauma emergency, They also may be on a medical emergency and be able to be distracted. So that's not right, right? But we see the answer on for what they're saying is trauma emergencies involve injuries resulting from physical forces applied to the body. Once again, this could be a medical call. Okay, so frequent flyers, people who call a lot, calls 911 because of a suspected head injury. You should never take the call serious, and don't waste your time because this guy calls a lot. Ooh, I don't know about that answer. Perform a primary assessment. He called for a head injury last week and it wasn't serious. Well, we're getting probably in a better place, but I don't know that that's right. Assume you know what the problem is. Every case is different, and you don't want to miss a potentially serious problem. That probably should say you should never assume that you know what the problem is. So already you're walking in going, oh, this is garbage. It sounds better. Treat the patient with respect. He's probably lying. Well, if you spend some time in EMS, you may or may not see probably all of these. And let's just be honest, when you get a little bit frustrated, you may or may not do A through D, maybe even on the same call. But let's talk about what we think. So a frequent flyer calls 911 because of a suspected head injury. You should never, I like C, assume you know what the problem is. Don't assume you know what the problem is. What you're saying there is, this is garbage. This guy has called 22 times in 2 months, and every time it's been bull. That's what you're saying. And you're saying, so this is too. Remember, every case is different, and you don't want to miss a potentially serious problem. Well, boom, you were right. So you're obligated as a medical professional to refrain from labeling patients and displaying personal biases. Never assume you know what the problem is, even when you're treating patients who frequently call. The attitude could result in missing a serious condition, and it's very easy to do. It's very easy to do. So let's take a look here. Take the call seriously. Don't waste your time. Never assume you know the patient's problems before you arrive. Every patient needs to get treated equally, right? We're here to take care of people. Sometimes we get frustrated. Sometimes we may or may not do such a good job at taking care of people, but at the end of the day, we're here to take care of people. Perform a primary assessment. He called for a head injury last week and it wasn't serious. Well, we should perform a primary assessment on every patient, right? But we shouldn't worry about that last week he called and it wasn't serious and, all of that. So, and he's saying you should never perform a primary assessment. Everybody should get a primary assessment, but we need to mark off the last part. He called for a head injury last week and it wasn't serious. Don't let that affect this week. Just like you in your life, we don't want our mess ups or last week to define this week, right? So same thing. We don't want to Billy Bob. He's got some issues, man. He calls a lot, but we don't want to ever miss something that's really wrong with him because of our own personal biases and our own issues. Assume you know what the problem is. Every case is different. Never. Now, remember, you're reading. You should never assume what you know what the problem is. So that's true. And then treat the patient with respect. He's probably lying. It's important that you maintain a professional, calm, non-judgmental demeanor at all times. And it's saying you should never treat the patient with respect because he's probably lying. So why would you? We know that's not right. Now, if your medical patient is not in critical condition, right, sick or not sick, we're saying he is not sick, right? Not in critical. How long should you spend on scene? 10 minutes or less, 30 minutes, 2 hours, or however long it takes to gather as much information as possible. Well, 10 minutes or less, probably not that. That's typically like a bad trauma call, going to be someone that's sick, right? Someone that we think may be dying pretty soon. 30 minutes, that may or may not take 30 minutes. The way I want you to read this is it's saying you need to spend 30 minutes on scene. Well, it may take you actually 10 minutes or less to get everything you need, or it may take you 42 minutes. So 30 minutes is not a good answer. 2 hours is not a good answer. You try that and you won't have a job for very long, probably. So however long it takes to gather as much information as possible sounds good. So in many cases, the time on scene may be longer for medical patients than for trauma. If the patient is not in critical condition, you should gather as much information as possible from the scene so that you can transmit that information to the physician. Now, critical patients always need to be transported, need rapid transport. Time on scene should be less than 10 minutes or less. That's what we're hoping for. 30 minutes, no set time limit for non-critical. 2 hours, once again, no set time limit. So however long it takes. Like I said, it may be 8 minutes. It may be less than that 10-minute trauma thing, or it may be an hour and 8. It whatever it requires. Your patient is having respiratory difficulty and is not responding to your treatment. What is the best method of transport? So what we're saying is respiratory difficulty, that's kind of a big deal, right? That's something that can kill somebody. It can evolve into killing somebody, let me put it that way. And it's not getting better. Well, typically things don't just stay static in life, and that has to do with the body as well, right? So either we're getting better or we're getting worse. It may be at such a minimal amount that you don't notice it, but that's typically what's going on. Energy doesn't do that. Everything in the body doesn't do that. Things either are getting better or they're getting worse for the most part. So what is the best method of transport? We're treating him and things are getting worse. Without lights and sirens to the closest hospital. Without lights and sirens, could, maybe not, to the closest hospital. Maybe not. Depends on the right hospital, and it depends. If with lights and sirens, we're saying, we kind of talk about that this guy's sick, right? So then we look at with lights and sirens to the closest hospital. That sounds pretty good. Air transport to a special facility located 30 miles away. You may or may not need air transport, depending upon where you are and all of that. I don't think, they probably need air transport. And then the patient does not need to be transported. Well, he's having breathing difficulty and he's not responding. So to me, it looks like we're probably talking about lights and sirens to the closest hospital. Yes, you're right. Patients with respiratory difficulty generally require high priority transport, especially if they don't respond to your treatment. If a life-threatening condition exists, the transportation should include lights and sirens. In this case, it is appropriate to select the closest hospital with an emergency department as your destination. So we're saying we're going to get there as fast as we can, and we're saying we're taking him to the closest place because he may just need some medicine that you don't have available. It's not that he may or may not need some advanced procedure and surgery and all of that. He just may need some albuterol and Atrovent, which is something that, depending upon where you work, you're probably not going to be able to do as an EMT. So without lights, respiratory difficulty is considered a high priority transport, right? We said this guy's sick and he's not getting any better and he requires lights and sirens. So with lights and sirens, well, we know that's correct. Air transport, so respiratory difficulty does not require a special facility. We're not looking for, a special facility. We just want him to go to an emergency department. And then all high priority patients should be transported. Don't get lazy and not take somebody that's not able to breathe well. When assessing a patient with an infectious disease, what is the first action you should perform? Well, first action, we probably should let's think about this, okay? So we're sitting at the station, all nice and cozy in our recliner, right? Maybe you got a little cold beverage, or maybe you got some hot chocolate because it's a fall or a winter day, or whatever it is you partake in. And you get the call. Probably regardless of whether they were to tell you that this man or lady has an infectious disease, what are you going to do? Probably, I hope you're going to put on your gloves. I hope you're going to put on your goggles or your glasses if you wear those and if your service wants you to. And then when we pull up, what are we going to do? We're going to obtain a scene size up, right? So that seems like a good answer. Size up the scene and take standard precautions. So PPE. Obtain a sample history. Well, yeah, but this is what, understand this, guys. When we're looking at this, this is the most important word right here. What's the first action that we do? Go back to your 5-3 ABC go. Within 5, we say we're going to size up the scene and we're also going to put on some PPE, right? Hand the patient off to a paramedic. That's the first thing. No. Cover your mouth and nose with your hand. May not be really very good way to protect yourself. So the assessment of a patient suspected to have an infectious disease should be approached much like any other medical patient, right? How many times have we said it? We're going to treat every single patient like they're sick. And one of these days, we're going to run into one, right? We're going to take care of one and we're going to be ready. So this is what we're doing here. So first, the scene must be sized up and standard precautions taken. Always show respect for the feelings of the patient, members, others at the scene. So we got that. A sample history. You must always ensure your own safety before assessing the patient. Hand the patient off. EMTs are qualified to assess patients with infectious diseases, and then cover your mouth. Action is not necessary. Most diseases are transmitted via blood or bodily fluids. Remain calm and be respectful. So your patient now believes he has hepatitis. and he's now exhibiting signs of cirrhosis of the liver. He most likely has hepatitis A, B, C, or D. Hopefully you've done a little bit of reading about this and you know that cirrhosis, when cirrhosis starts developing and in what, I don't know if the right word, strain or what type of hepatitis, but hepatitis C. And the answer is C. So cirrhosis of the liver develops in 50% of patients with chronic hepatitis. So your patient believes he has hepatitis. So cirrhosis of the liver is not an indication in hepatitis A. Hepatitis B, once again, not an indication. Hepatitis C is correct. And then D, cirrhosis of the liver is not an indication. Hepatitis C is the one that we're talking about with cirrhosis. So just remember that. Cirrhosis starts with a C. Sounds like it might start with an S, but it starts with a C. And what hepatitis does it affect? Or when we find it, hepatitis C. So kind of an easy way to remember that. Your patient is complaining of fever, headache, stiffness of neck, and red blotches on his skin. He most likely has, he's got cooties, I bet. So stay away because you do not want cooties. Anyways, I digress. Let's talk about this though. Tuberculosis, I don't know. Hepatitis B, I don't think that we're expecting all of these things with hepatitis B. SARS, probably not something that we all know a lot about, but I bet we've learned a little bit more about it recently with the big COVID deal. And then meningitis, right? Infection of the meninges. So what do you guys think? Tuberculosis, a breathing thing, hepatitis B, SARS, meningitis. What was that? I heard you in the back. Yep, I agree. Option D. Patients with meningitis will have signs and symptoms such as fever, headache, stiff neck, altered mental status. So patients with meningococcal meningitis often have red blotches on their skin. However, many patients with forms of meningitis that are not contagious also have red blotches. One important part here, a couple of things that should send up the old red flag for you, okay? Really, all of these signs and symptoms, but fever, if we don't see a sign of infection, a source rather is what I'm thinking of, is a source of infection. Headache, but this stiff neck. So one thing you can do is if you think they might have meningitis or they tell you all these signs and symptoms, you can have them try to touch their chin down to their chest. That is a really good indicator of whether someone has meningitis because those meninges, that lining gets inflamed and it won't allow movement as well. I'm trying to think of the word, the big fancy medical word, but I can't think of what it is, and I probably will as soon as I end this. But anyways, that's what we want to do is check for stiff neck also. So TB, not indications of TB, not the signs and symptoms of it. Hepatitis B, not indications of that either. SARS, not those indications either. Meningitis is the correct answer. And I just remembered it, nuchal rigidity. That's what the stiffness of the neck is nuchal rigidity for you or your patient to stick your chin down to your chest. Now, maybe you got some, a little extra stuff or your patient's got some extra stuff down there. It makes it a little harder, but that doesn't count if you can't. It's just not about not being able to touch your chin to your chest because, let's just say some things are in the way, like a couple of extra chins. What we're talking about is the stiffness that will not allow you to move that way. Now, what should you do if you're exposed to a patient who is found to have pulmonary tuberculosis? So get the vaccine, get a TB skin test, undergo serious therapy, no precautions. You've pretty much got everything here, right? You've got, don't worry about it, all the way up to serious therapy, like you probably need a surgery or something. B, exposed who is found to have tuberculosis, you will be given tuberculin skin test. This simple skin test determines whether a person has been infected. You've probably all had those where they put that little bleb underneath the skin and within 24, 48 hours, they look at it to see if it's gotten red and swollen and inflamed and all of that. So the BCG vaccine is only rarely used in the United States. TB skin test is sufficient. Serious therapy is not necessary. We don't even know. We're going to do that skin test first. Okay, last one. You guys have been doing good. Let's hit this last one. Let's knock this out of the park. All of the following are factors that increase the risk for developing MRSA. Remember, we talked about what that is. It's resistant, right? A resistant strain. So except antibiotic therapy. So all the following are factors that increase the risk. So antibiotic therapy, well, we kind of know that MRSA is due to excessive, or one of the things is excessive antibiotic use. Prolonged hospital stays certainly could be. Exposure to an infected patient certainly could be. Or close contact with wild birds. Seems like a pretty random answer. But there is some things that, I don't know about wild, but like chickens and stuff, weird things go on. Chicken flu or something. So D, factors that increase the risk for developing MRSA include antibiotic therapy. We said that. Prolonged hospital stay in ICU. That's a pretty intense one. And exposure to an infected patient. So close contact with wild birds is a factor that may increase the risk of acquiring the avian flu, the old bird flu. So here we go. All of those were factors. Last one is the correct answer. You guys, once again, did amazing. 10 for 10. Good job. And we will talk soon.